Shai, first of all, thank you very much to both Justin and you for inviting me to this course, which I think is something I would have loved to have had when I was at your stage. It's an absolutely fantastic program you've put on and a really logical progression through the day. It's my pleasure to give you this talk on angiographic views. I work here, which is a fancy way of saying Ealing Hospital, and there, which is a fancy way of saying Ealing Community Cardiology. So as and when we can progress the slides, I'll tell you what we've got planned. So I'm aware that there is a breadth of kind of experience here, but I think it's important really for all of us that we start with just some basic coronary anatomy revision. It's not going to hurt. And then I'll just take you through the coronary views, get you familiar with the nomenclature, and then really focus on getting you to choose the correct view for what you're trying to achieve. And then a couple of cases to kind of consolidate what we've discussed and to show a couple of pitfalls. It's you're amongst friends. There's, if I ask a question, answer it. If you don't know, that's fine. Ask me. So before you start, certainly I know when I was a cardiology trainee, I would go to these training days and everyone would go, how many angiograms you've done this year? And I'd say 100. They said, I've done 500. And someone said, well, I've done 1 million. And it's all nonsense. Actually, what you've got to do before you kind of press the start button and race off is do your safety check. And I think you've had a talk on this in the morning. So before you start, make sure you're doing the procedure for an appropriate indication. Angiograms, you're a technician at the end of the day. You are going to be asked to do a procedure from someone who may not have done much in the way of clinical cardiology. So make sure, and don't be scared to say, you know what, I'm not entirely sure this is the correct thing to be doing. The next thing is make sure that the patient knows exactly what they're in for, they're consented, and it's safe to do the procedure. If they're looking anemic and pale, think about it. Look at their blood tests, look at their renal function, and just see that they haven't got a high temperature and that. Make sure the patient is safe, as we've already said. Then appropriate access site. Now, when I trained, it was femorals first line. I did about 300 femorals, and then someone told me you could do this radially. Nowadays, radial is clearly the way to go. Radial is first line because it's a safer access site. There's less bleeding, and that translates to better outcome. What I'd say to you as trainees just starting off is don't ignore the femoral, because I know the person who taught me radials, a consultant, would start sweating when he couldn't get through to the radial artery, and suddenly his hands were shaking. And from being an high school interventional cardiologist, he was absolutely paranoid about femoral access. So the way I'd say it is, if you've got someone with grafts, go femorally, and that way you get an appropriate experience in both. Vaz very correctly said, look at previous cath lab procedures, see whether the operator had problems. It tells you what catheters to choose, and also what the coronary imaging looked like last time. If there was a mild to moderate plaque, you may want to focus on that more, because that may have progressed, or their symptoms have progressed. Finally, Shai's alluded to the fact that I'm not an imaging guru. I do a bit of MRI in my spare time. But a lot of that involves functional imaging. So if someone is symptomatic or they've had a functional test like a stress echo that suggests ischemia in one particular territory, you're going to want to think, actually, when I'm doing the angiogram, I need to think, is there a problem in the LAD? Also, how typical is the history? If they get crystal clear exertional angina, if you're seeing a normal coronary angiogram at the end of the procedure, think again. Equally, if their pains are completely atypical, they haven't had a functional test, the chance of a normal angiogram here is not unreasonable to see a normal angiogram. So I'd always say look at the report from the functional test. If you've got the skill set, look at the images. The report tells you the report is basically black and white words. The images will actually give you an idea of whether there is any significant ischemia. So that's what you do before you start and race off and try to do your 10 angiograms in a day. So basic coronary anatomy, you've got two coronary arteries. You've got the left coronary artery, left main coronary artery bifurcates to the LAD and the circumflex. I'll just race through this. I'm sure you know all of this. The LAD supplies the anterior and the septal walls of the left ventricle, the circumflex, the low lateral walls. The LAD gives diagonal and septal branches, and the circumflex gives OM branches. So that's a diagram here, and that's your angiographic view. We'll talk about what the actual views are in a minute. You've got the other artery, the right coronary artery, which comes off the right coronary sinus and goes in the right atrioventricular groove, so it gives you a PDA-PLA bifurcation. The PDA supplies the inferior surface of the heart. You've also got branches further on, the conus branch. You intubate that, inject, you get VF, as we've already heard. You've also got the right ventricular branch. So two coronary arteries, the left coronary artery bifurcates to the LAD and circumflex. The right coronary artery comes across typically from the right coronary ostium, and in about 80 to 90% of cases will give you the PDA, and that is what determines what artery is dominant. The right coronary artery may be tiny, we call it non-dominant, and the circ will be a lot larger and give the PDA branch, and that's about 10 to 20% of cases. I'm assuming we all knew that already, and this is just basic revision. Hands up. If this is all new to you, let me know, and I'll dwell a bit longer in the next few slides.
Is everyone comfortable with that? Because, yeah.
Coronary views nomenclature. I know when you first get into the cath lab, all I heard were PA cranial, LAO cranial. What the hell does all of that mean? Very simply, your patient's lying on the bed here. You've got the image intensifier, and it can go in two planes vertically. It can go towards the head end of the patient, that's cranial. It can go towards the tail end of the patient, that's caudal. It can also go left and right. Okay, so the left of the patient is LAO, to the right of the patient is RAO. Now you can mix and match all of those, and in essence get a variety of imaging planes. What we're going to teach you is which imaging plane to use for which coronary arteries and how to approach it. So let's start with the left coronary artery view. Very busy slide here, but in essence you've got 6 imaging planes you can use. You've got the cranial views, which you can do in LAO, AP, and RAO, and you've got the caudal views, which you can do in LAO, AP, and RAO. You can have what we call a lateral view, but that's best avoided as a high radiation dose, but there are specific indications you may want to adapt. So potentially 6 views that your workhorse views in left coronary angiography. Right coronary angiography, if you try and do all 6 of those views for a right coronary angiogram, you are going to get someone at least giving you a quizzical look. If it's me, I'll come and ask you exactly where you trained before, who taught you, and give them a phone call. The 3 views here, the LAO, the cranial, either AP or LAO cranial, and the RAO. And again, we'll go through what each of these views are used for. So first learning point, no more than 3 views for the right coronary artery. If you're doing 6 views, something has gone horribly wrong. What views do I choose? Well, option 1 is take images in every projection I've ever heard of. Option 2 is you take a tailored approach for every patient depending on the clinical picture, and also takes an interactive approach. So as you're looking at the images, you're thinking, well, I may need to do another caudal view, I may need to do another cranial. So real-time review of the image acquisition. So what are the pros of option 1? You won't miss anything. But obviously there's a radiation and contrast dose, and you look like a robot. And for me, when I see a trainee, it's a sign they don't really know what they're doing. And all of you come here going, I've done 1,000 angiograms and I need to do some angioplasty, and you've been doing a job for 6 months. And that to me is a big tell. When you see them just going around the houses, taking every view, and it all looks normal after about 3 shots.
So you know what to do now if we just take one.
I'll tell you what I do, but I know cardiologists who do take one, and that's has also got its own problems associated. Option 2 is, as I've suggested, and I'll put it to you that this is the correct approach. The CONSART takes experience, but it's not because you're not experienced, it's not a reason not to do it. You should be supervised if you're not experienced, so that actually you learn what the views are. And really the end point of option 2 is you've visualized every segment of the coronary artery appropriately. So when I first got into the cath lab, I'd take the robotic approach, and I'd look at the screen going, which one's the LAD, which one's the circ? They all look the same to me. Well, it's very simple. In essence, just as a rule of thumb, in the caudal views, you're going to see the circ very well, and the cranial views, you're going to see the LAD very well. So here we've got, in a caudal view, the circumflex artery splitting into its various obtuse marginal branches. And you can see, you pretty much see the whole course of the circumflex, right from the ostium, right to the distal end in a caudal view. In the LAD, you've seen the proximal LAD beautifully, and then there are all these overlapping branches. And about here, you don't have an entire clue what's going on. In the cranial view, you can see the LAD here in its entirety, all the way down. And conversely, the circs start to becoming overlap. So as a broad rule, lesson 1, broad rule of thumb, caudal is great for circumflex, cranial is great for LAD. Now what about LAO and RAO? If you're just looking at images, how do you know which one's an LAO and RAO? A couple of points. I don't think it's particularly critical to recognize what view, as long as you recognize which vessels. But for example, an LAO-cranial that we have here, you know it's going to be cranial because you've seen the LAD beautifully. You know it's going to be LAO because the LAD is on the left-hand side. The rule of L's, 3 L's, LAD, LAO. Also, you know that it's going to be LAO because the spine's on the right side of the image. In an RAO projection, the spine will be on the left side of the image, and the LAD will be on the right. But the key learning points here is caudal views for circumflex, cranial views for LAD. So let me just first of all declare, it's a lovely slide, I didn't make it. I stole this off the internet, I will credit whoever. But it shows you here on the top panel, we'll go literally view by view. So I always start RAO caudal, and that's what the camera looks like. Actually, I don't always start RAO caudal because it kind of smacks me in the face. I always go PA caudal, but when you go RAO caudal, the camera is coming towards you. And when you take the images, what you've got is a beautiful view of the circumflex right from the ostium all the way to the tip. LAD is well seen proximally, mid to distal is a bit less well seen. And you see the left main stem very well. And that's the position of the camera. So RAO caudal works very, very well for the circumflex. PA caudal, you've just rotated slightly. You can actually see the distal OM vessels very well. You're still seeing the circ beautifully. You're seeing the mid to distal LAD now even worse. So that's just to refocus, re-emphasize caudal for circumflex. Now, no view is mandatory, I'd say, but the spider, I think you'd be hard pushed to defend not including it. The spider is the one view in practically every angiogram that I've done that I've always taken. And that's because it tells you about the proximal vessels in the left main stem. And sometimes when you first start, you may just do a quick screening shot in the shallow RAO. If you think there's left main or critical proximal LAD, I'll go straight to spider because you want to minimize your views at this point, and the spider is an essential part. And in critical distal left main, and occasionally you'll have that moment where you take a sharp intake of breath as you see the whole left coronary artery system hanging on by a thread. And if you sit there taking your robotic option 1 view, it'll be a VFRS, you take minimal shots. Spider has to be one of them and 1 cranial shot to get the LAD. And again, you can see where the camera is. That's your LAO caudal view. Now onto the cranials. And you can see what we're doing is we're going RAO caudal, PA caudal, spider. We're actually going in a logical manner. What you don't want to be doing is going zigzagging backwards and forwards because you'll soon get feedback from your radiographer, the nurses, about what they think about all of that. The LAO cranial view is something I don't use very often simply because the bottom end of the image intensifier comes and whacks me on the knee. But is actually something that you should use if you're particularly worried about the LAD diagonal bifurcation, because you see that beautifully. It's also very good for the ostium of the left main stem, and as I've already mentioned, you see the whole course of the left anterior descending artery. You've got other options, the AP cranial, and again, you're not seeing the circumflex brilliantly here, but you are seeing the whole course of the LAD very well. And then the RAO cranial, which is another projection. Now, what's my approach to the left coronary imaging? As a general rule, I take a shallow RAO just to start and figure out where the action's going to be. And if I noticed from the shallow RAO as a potential LAD lesion, I'm going to focus on the cranials, may even take them first. If it all looks normal, then I typically take 2 caudal views, the spider being one of them, and the PA caudal being the other, and 2 cranial views. I will take the LAO cranial if I've got any concerns about the LAD diagonal bifurcation. Otherwise, I tend to fly with the PA and the RAO cranial. The key thing is to be dynamic, be adaptable, not go with a robotic approach. You may need to take all the shots. I haven't mentioned the lateral, but sometimes you take a spider view and you haven't really kind of got the LAD and the circumflex separated. And the spider's very good for that because it really splits it out, and the vessel closest to the sternum is going to be the LAD. So that's the left coronary done. The right coronary is much quicker to talk about.
Okay, yeah. So you focused in on kind of angiographic views, but what about radiation? Are you going to talk about that?
It's not included in this talk, but I mean, obviously, the concept of radiation is to minimize radiation doses. Screening gives you a smallish dose of radiation. The real dose of radiation that you get is during acquisition. So it's a good point you bring up because it's very simple to adjust all of this. Tailor the approach, minimize the views, but also when you acquire for 1 or 2 cardiac cycles. I see registrars who literally are acquiring pressing the button. And sometimes when you're learning, you forget sometimes to take your foot off it. It's like driving a car, and eventually you get very good at it and you can do it very fast.
And what about different views? So like, for instance,
The lateral view we don't do because it's incredibly high radiation.
Elliotocranial as opposed to a caudal view, is it going to give you more or less exposure? Or?
So again, it depends on the body habitus of the patient, but I think as a bare minimum, 2 caudals, 2 cranial. So I think even if there are radiation issues, I would at the bare minimum suggest 2 of those. I mean, this is an invasive procedure. You are not going to get another chance necessarily to image these patients again. So those are the bare minimum, and that has the implication of reducing the radiation dose as well. Okay, so right coronary artery, straight LAO is where you start. Vaz has very elegantly explained the joys and delights of trying to cannulate the right coronary artery. It's done in LAO. And this is kind of your mandatory, the equivalent of your spider. You have to have an LAO simply because you intubate in this view. And it gives you an overall idea of where the action in the right coronary artery is. And then you've got the PA cranial, which really splits apart the bifurcation. In the LAO, there may be some overlap between the PLA and PDA, and the PA cranial will open this up beautifully for you. The RAO gives you a really good view of the mid-RCA, but you can't really see the PDA and PLA bifurcation. And my approach is I tend to use an LAO and AP cranial. If there's any lesion in the mid-right coronary artery I want to have another look at, and again, someone told me that you only really start becoming good at coronary angiography when you start thinking like an interventionalist. So if you think there's a lesion there and you want to make sure you've got the right size stent or the right size length, if it's in the mid-right coronary artery, having an RAO is also going to help you pass the wire through successfully. There are lots of branches. So that's basic, the basics of kind of what coronary views you choose. I was asked to make this case-based, so I've actually just picked a couple of cases from the cath lab at Ealing. So there's this case, a 55-year-old man with a single episode of chest pain. And this is a coronary angiogram that was undertaken. So the first question is, what view is this? Well done, okay. So you know it's a caudal view because if we just go back that slide, you're seeing the circumflex beautifully and the spines on the left side of the screen. Any thoughts on this? What do you think of is that a single episode of chest pain, no pain? What are your thoughts? Obviously you need to see some more pictures. Well, let's take you forward. Let's give you a cranial view perhaps. Any thoughts now?
So subtaste occlusion of the diagonal.
Diagonal. So where's the LAD?
It's along the edge of the heart. Okay.
Yeah. And what view is this, do you think?
This is a AP.
Cranial or caudal?
Caudal.
Okay, so the spine's on the right side. It's an LAO. And if I told you this was a cranial, LAO cranial, where would you see the LAD? Are you really seeing it?
Not really.
Let's go forward. Let's give you another view. What view is this? Okay. What vessel is this? What's this? Intermediate. So what's missing over here? So it's completely occluded as LAD. And the caveat here is obviously you get a very obvious clue here. You've got this late filling of that vessel. You're seeing it in all views. But there have been patients who I've seen who presented with chest pain, raised troponin, and you do an angiogram, and everything looks normal. And actually in this spider view, and I couldn't find the case yesterday, you've got an LAD that goes down. It looks beautiful. You've got a circ that goes down that looks beautiful. And you think it's all right, everything's all right. Not everyone's going to have a large intermediate, but the clue is sometimes in a nubbin. So think about flush occlusions if it doesn't fit the clinical picture. Someone presenting with an ACS, because if you poke with a wire, you may open up something as big as that. Okay, so let's move on to the next. This is still our 55-year-old man. And what we've done here on the right coronary artery, what can you see we've done here? What's different between this picture and the last couple of pictures? I mean, this is relevant to the radiation acquisition. Yeah, it's a longer acquisition, there's a greater radiation dose, but why have we done that? Yeah. And can you see anything here? Yeah, so if I can convince you, yeah, you'd hope to see better collateralization, but we can see the LAD filling very late on there. And that's important. You're going to send this guy for surgery. The surgeons are not going to have a clue what kind of distal vessel they're going to have to deal with. Okay, we'll go to the next case. So this is a case of a 61-year-old man who went for an endo-ACAB to the Royal Brompton. That's a minimally invasive procedure where you can put a lima onto the LAD. Fantastic procedure in terms of quicker recovery. A lot of our patients at Ealing have some form of absolute antibodies to having any form of midline stenotomy. The minute you tell them there's a little scar on the side, they're more than happy to have it. So the patient presents after the operation. They're about to discharge him. He goes, well, actually, I don't want to go home. Every time the physio walks me down the ward, I get chest pain. So this is pretty classic angina. So the surgeons are kind of scratching their head and saying, what's going on? They go and look at the angiogram. And this is the picture of the right coronary artery. What do you think of it? Big right coronary artery, small right coronary artery? Any lesions? Non-dominant? Yeah, okay. So no, there's nothing there to get excited about. Let's go to the next picture. What view is this? Caudal or cranial? Caudal, what kind of caudal? Arachnoid, yeah, so it's a spider view. Anything exciting here to see in this, on the circ? It's a bit cruddy, isn't it? It's just a bit atheromatous, but it's not particular. You've got a non-dominant right, so that should be given off the PDA. The LAD, not really seeing it, is a bit of overlap, so let's go to the next picture. Any issues? And so they're just looking at the angiogram picture beforehand, and what they're looking to find is there something that we haven't grafted? Was the LAD lesion perhaps not as significant as thought? We all know that coronary physiology is critical before we send anyone for revascularization. This lesion had been properly assessed with a pressure wire and was significantly positive, and the patient clearly had angina. So next slide. So what's gone wrong here? Well, the lima may have failed. That'd be disappointing. This is non-cardiac pain. That's highly unlikely. It's angina. And there's another lesion not grafted. Could any of you see anything critical going on? Diagonal, yeah. So lima's the LAD. You may have missed something in the diagonal. There's quite a couple of quiet diagonals, quite significant diagonals. So let's go forward. So we cathetered, didn't we? Diagnostic angiogram. So here's the right coronary artery. Does it look different to what we did before? Okay. So let's go forward. There's a critical lesion there, isn't it? And this shows what the problem is. Okay. That is the branch. Yeah. And let's go forward. And it all ends very happily. He has PCI. So the idiot who did that angiogram was me. Thankfully I did the PCI to sort it all out. It happens. What's that?
You plan for a hybrid, basically. You always plan for the lead to the end.
Yeah, you actually steer away. I hadn't thought of that. Any questions at all?
Are there any clues that you've done? Because you can do that all the time.
Yeah.
It's just
so I take great comfort in the fact that the real YMs of interventional cardiology, and I'm not one of them, have done similar things. It can happen. The clue, I suppose, in retrospect, is when you look at the circumflex, it was not massively dominant. We all have off days. Thankfully, actually, as Suk very thankfully pointed out, this has a positive spin on it. The hybrid procedure where you do an endo-ACAB and a staged PCI is something that's actually being evaluated in an academic manner to see whether it's better than just standard conventional grafts. So I think if your circ's not massively dominant, what I should have done is push the catheter down further, and there's actually a TIG catheter, which tends to point upwards and twist in a bit, and we would have seen that there's a massive right.
So any questions to Ravi about views? Anything there not quite clear?
If you can't see the proximal LAD very clearly, do you prefer to use a PA cranial or PA caudal?
So I think for the proximal LAD, the spider for me is the best view. Obviously, if it is a particularly tortuous spider, then I think just take a composite of views. Focus on the caudal, on the caudals. The LAO cranial can sometimes also show you that LAD-D1 bifurcation, just the proximal segment. Obviously, the proximal LAD is not an area where you want to be missing significant lesions. And the other thing to say to you is, if you have a normal coronary angiogram, I've already said this, and the patient gives a classic history of angina, just have a really good look that you haven't missed something. I'm the consultant in the lab, but in those circumstances, I will ask. We've got very experienced physiologists. I go, has anyone else here seen anything? I'm certainly not shy enough to ask my colleagues. So I certainly, I wouldn't recommend you do things. The worst thing you can do is pull the sheath out, and then someone comes up and goes, well, what's that? Why don't you look at that? Why don't you take a different view?
Great.
All right.
Fantastic.
Okay, so.